How's it going, guys? Past level question immunology. We got a 7-year-old boy undergoes bone marrow transplant for ALL. He develops diffuse rash, fatigue, profuse watery diarrhea, increased ALT, AST 2 weeks later. What's most likely responsible for his presentation? Choice A, antibody response against graft antigen is wrong. That's hyperacute rejection. That's where we have preformed antibodies against antigens such as in xenografts. Those are animal grafts. If you try to implant a bear heart, a pig heart, they'll be instantly rejected on the operating table. The USMLE question can describe it as thrombosis of vessels seen on the operating table within minutes, preformed antibodies, and occasionally they can have B cells as the answer for that because B cells make antibodies, right? B cells, paternoplasmals, antibody production, but it's preformed antibodies for hyperacute rejection. Wrong fucking answer. Choice B, cytokine response mediated by macrophages, toll-like receptors is wrong. It refers to endotoxic shock. So in terms of sepsis, if you have the lipid A of LPS from gram-negatives, endotoxin, binds to toll-like receptors, aka CD14 macrophages. Macrophages release cytokines. TNF-alpha, increased vascular permeability, low blood pressure, vasodilation, IL-1 fever. This mechanism contrasts with toxic shock syndrome, Staph aureus, and toxic shock-like syndrome, strep pyogenes, group A strep, because those two are exotoxin superantigen that will bridge MHC2 on the macrophage with T cell receptor on the CD4 T cell, causing the macrophage to release cytokines. If they give you cotton packing in the nose, it's not just tampons, but cotton packing and shock, the answer is going to be T cell receptor and MHC2. If they give you a cellulitis with shock, it's going to be exotoxin A of strep pyogenes, T cell receptor MHC2. And that contrast, as I said, with CD14 toll-like receptor of gram-negative, the lipid A of LPS. Wrong fucking answer. Choice C, B cell mediated immune response targeting recipient antigens is wrong. It's basically nothing you should know for USMLE, okay? Very rarely you can get graft-versus-host disease variations where there's a B cell response from the graft onto the host, but that'll get you questions wrong on USMLE, so I don't want you to know that, okay? Wrong fucking answer. Choice D, host T cell response against donor antigens is wrong. This is normal, acute, and chronic rejection. So we said hyperacute was antibodies on the operating table within minutes, the rejection. Host is your recipient. Donor is your graft. So if they give you weeks to months later, there's a rejection. That's acute rejection. That's a mixed CD4, CD8 T cell response mounted by the host, by the recipient, against the donor / graft antigens. If it's 6 months plus, that's chronic rejection. That's predominantly a CD4 T cell response of the host against the donor. Okay. They do ask that somewhere. They want you to know that chronic is more of a preponderance of CD4 T cells, whereas acute tends to be more CD4, CD8 mixed. TCK step 3 level stuff, you should know that if there's a transplant, that 6 months later, they tell you there's decreased function of the transplant, that before you do a biopsy, you can simply increase dose of corticosteroids. Shows up on a 2CK form. Choice D, wrong fucking answer. Choice C, T cell response of donor against recipient. Correct answer, it's graft-versus-host disease. So he said graft is the donor against the recipient, which is the host. So it's kind of the reverse of classic rejection, right? It's considered a type 4 hypersensitivity. Bone marrow contains a lot of T cells, and you have a depleted immune system in the recipient. And the mechanism USMLE wants you to know is that the donor T cells attack the recipient's antigens as foreign. That's what you have to memorize. They'll have that worded in many different ways, which can sound confusing. And the answer is donor T cells attack the recipient antigens as foreign. And it's a mixed CD4, CD8 response. Graft-versus-host disease can present as a triad of rash, which interestingly, it can be palms and soles initially. You don't think of it as a classic palms and soles rash, but it can be palms and soles. And profuse watery diarrhea and transaminitis. That's a classic triad seen with graft-versus-host disease. So it's an important mechanism for USMLE. You know the deal. I'm going to make more content on your subscription channel. Appreciate your time. That's it.